Thank you very much to you all for joining us this afternoon. It's great to be here in San Francisco for ASTRO, and it has been just an incredibly busy few days already for Leo Cancer Care. Lots of exciting new announcements that I'm sure many of you have seen. The biggest of which, just to give a few updates here, the biggest of which, the 510K now for not only Leo Cancer Care's Marie Upright system, but also now the integrated proton therapy products that we partner with. So Mevion, for example, has also received the 510K for their FIT product. We are going to have a celebration for that. Anybody who's been through the process of developing hardware knows how hard that is to get a product through a 510K clearance. So we will be celebrating that in style on the Leo Cancer Care booth at about 4 o'clock today. So anybody that wants to come and celebrate in that moment with us, you would be more than welcome. As well as just the proton therapy announcements, we also, during this ASTRO show, launched our first ever LINAC product in the conventional radiation therapy space, named Grace. And I can see there's some information on that on your seats today. And this is a really important development, not just for us as an organization, but I believe for our industry. Proton therapy has been our focus over the last few years, and we've been able to, as you'll see today with some of the talks that we'll go through, we've been able to really redefine the way that people think about protons. For many, many years, people said it was impossible to put proton therapy inside of a linear accelerator vault. Now, and with the tour that happened at Stanford just a couple of days ago, we can see that that is now a reality. So that is a huge milestone for our industry. But what we're also seeing now with photons is broader adoption. People not just looking at this as a niche area within proton therapy, but broad adoption to the idea of treating patients in the upright orientation. That brings those benefits, those advantages that we see to more patients across the world, but it also now significantly increases the industry investment into upright radiation therapy. So we are truly now expanding across the entire space. We've also, during the course of ASTRO, announced a new partnership with Sumitomo. So Sumitomo is the latest vendor that we are working with to offer upright proton therapy solutions. So something that we're really excited about and will give us greater geographical reach to our technology as well. So they're just a few updates from me, but I promise you, you're not going to sit and listen to me talk for 57 minutes, thankfully for you, or luckily for you. We have far better, more exciting speakers that are coming up to the stage in just a second to cover a broad range of topics around upright radiation therapy. So I'm going to be joined in just a second by Dan Medrano from the McLaren Proton Therapy Center in Flint, Michigan. And he's going to be talking about the differences that they've seen, being an existing proton center before we met them, the differences in proton therapy with and without Leo Cancer Care. I'm then going to be joined by Dr. Enk from, have I got the order in the right way there? Okay. Dr. Enk, who's going to be coming up and talking about their pathway to delivering proton therapy to the University of Nebraska. And then finally, Dr. Mehta, who will be coming and talking about what the future might look like within upright radiation therapy and other applications as well there. And finally, we'll be wrapping up with Rock to go through any questions. So without further ado, we'll make a start, and thank you all again for being a part of this.
Well, as Stefan said, I'm Dan Medrano from the McLaren Healthcare Corporation, and thank you for letting me come today and talk about McLaren and my experience of increasing access to proton therapy by the reduction in initial capital costs. So, for disclaimer, McLaren Healthcare Corporation is an institutional investor in Leo Cancer Care, and I am a non-scientific consultant to Leo Cancer Care. Later in the presentation, I'll also be talking about Pyramid Technical Consultants, who is a software and hardware company in Boston with an office in Vietnam that sells software and hardware for the accelerator industry. For disclosure, McLaren also is an investor in Pyramid Technical Consultants, and I am a board member at Pyramid Technical Consultants. So who is McLaren Healthcare? Well, we're a medium-sized healthcare, totally integrated healthcare system in Michigan. We do about almost $7 billion worth of business a year. We are a not-for-profit. I like to joke we're a for-profit, not-for-profit. You have to have that mentality of trying to make money so you can reinvest it into healthcare. But 14 hospitals, 28,000 employees, 113,000 network providers. We have almost 500 specialty physicians and primary care physicians. And we have a couple insurance products, and we insure almost over 700,000 insured lives. Probably for cancer care, more importantly, we have a wholly owned subsidiary, the Karmanos Cancer Institute, based in Detroit, Michigan. It's one of the 57 comprehensive NCI-designated centers in the country. There's actually 2 in Michigan, Karmanos Cancer Institute and the University of Michigan Cancer Institute. But we are also the largest provider of cancer care in the state of Michigan. We have 16 locations, and we have a hospital with 120 beds in Detroit, Cancer Hospital in Detroit. This is the McLaren Proton Therapy Center. On the left side is an addition that we did to an existing radiation oncology center, and it is located in Flint, Michigan. Oh, I'm sorry, going the wrong direction. So what do we have? We actually have 3 treatment bays in which 2 of them have 180-degree rotating gantries. These rotating gantries are 120 tons each. They take up the space of 3 floors. We thought we were saving money because we didn't do a 360-degree gantry. We cut that size in half and put in a 180-degree gantry, or else it would be much bigger. But we had 1 shelled room, and consistent with the review of what we should do in that shelled room, because we had got to capacity, and we did not want to turn patients away. And so we needed to take a look at how we would fit out the 3rd room that was set for a 180-degree gantry. And so 5 years ago, we began a process of doing due diligence. And it required from the staff that we do due diligence in a rigorous way. So we did due diligence on the academics, the hard science, the clinical applications, and the financial performance of different models. I started off by reviewing a new gantry solution. And if you can imagine with physicians, they're resistant to move away from a delivery type. So we wanted to make sure that we looked at all options. Well, one of the options during that process as we began eliminating gantries was the option of treating in the upright position. And what was intriguing to us was the concept of, instead of rotating the beam transportation elements around the patient, why don't we fix that beam transportation system and rotate the patient around the beam? To us, a novel concept that was out there. And 5 years ago, Stefan, I was looking at my email. So the fall of 2020, we had beginning the dialogue of this new concept of treating patients in a more humane position. And let's rotate the patient around the beam instead of the beam around the patient. So easy to say, harder to do. And so we came up with a solution at McLaren, and one of the advantages of McLaren is that we own our proton therapy equipment. We are both our own vendor and our own user. And so we came up with a concept of splitting the beam transportation line and switching the beam into 2 different rooms in which we would build at the grade level floor inside the 3-story vaults. And so what you see here, whoops, wrong direction. So what you see here are the 2 rooms, and we fit them in the size of the 3-floor gantry. So you can see we didn't need the below space floor, and we didn't need the penthouse space. We just needed this at grade, and we fit 2 rooms in the footprint of a room that was going to have 180-degree gantry. One of my colleagues that helped me with this process is, I don't know if he's in here, Dr. Vahagan Nazarian. You always have to have, clinical experts at the table when you're discussing these things. But one of your colleagues, if you're a radiation oncologist, Dr. Christian, of course I'm having one of those moments of forgetting his last name, Dr. Christian Hyde, he said, looking at your optics, I think you can fit 2 rooms in the space of 1 gantry. So, of course, your mind starts thinking, like, how many patients we put through 2 gantries, 2 rooms. We could double that in 1 room, basically a room A and a room B. And so, easier said than done. What we needed to do then was to find the technological ability to do that. And one of the benefits of our site at McLaren is that on my staff to maintain the proton equipment, I have both PhD physicists for actually the hard science of the accelerator, as well as applied science, applied physics. Then I also have PhD level software writers, robotic writers, motion control experts, and more importantly, the ability with our subcontractors to develop a solution that required us to do our own optics, create our own new larger bore quadrupoles, create a switching dipole to switch energy from rooms 3A and 3B, some doublets quadrupoles and XY guiders to guide the beam to a nozzle. But the biggest probably technical issue that we had to solve was that the nozzle was required to be like 50 centimeters farther away from isocenter, which required us to come up with optics and hardware that addressed a reduced water equivalent thickness. We increased the bore size of the quadrupoles, and we did some other things to come up with a solution that looks like this. So this is the bending magnet down the normal, or the switching magnet, room selection magnet for the beam line that goes this direction to the other 2 rooms. And then here we picked up a new design with this quadrupole for focusing, this design of a switching dipole that switches energy from one beam line to the other with 17.5 degrees from center line going left and right. And then these are the quadrupole doublets that we created. And then obviously all the support structure. And then in here we have an improved nozzle with improved ionization chambers and some specialty monitors that we put in. And then you see we did this with the Leo upright chairs. So from the beginning of this optics, we based it on our partnership with Leo that we could produce a beam transportation system and a nozzle that could treat with their patient positioner and their imaging solution. This also required then the integration of those devices. So we know in the industry, integration of these programs is quite an undertaking. So these are a couple photos. These rooms are finished out, but I wanted to show it in progress because you can see the Leo upright chair here, and behind it you can see the room where one of the beam transportation line comes in. And this is actually a beam transportation line with some members of Pyramid Technical Consultants, but we're showing it to one of the vendors out there. But this is all designed by McLaren, our partners, in conjunction with Leo Cancer Care. So one of the things about McLaren Healthcare, our very mission statement says that in the areas we treat, we want to have the best outcomes based on quality and cost. So it's important that individuals like myself throughout the organizations look to ways to reduce costs to the system and increase access. So by reducing the cost of delivering proton therapy, we believe we can create greater access. And this is just a side-by-side comparison of my experience between what is eliminated when you stop rotating the beam around the patient. Well, the very first thing is you eliminate 180-degree gantry. If you had a 360-degree gantry, it'd be even more. But that delta in today's dollars for me by eliminating just this 120-degree gantry is $1.6 million. You eliminate all of the components of the gooseneck on the transportation system, which are the quadrupoles, the dipoles, beam position monitoring, beam stops, the vacuum system, the power supplies. In today's dollars, I would value that at $1.2 million. Again, these are numbers from our experience. And then you eliminate 3 levels of concrete. So the 3-story rooms took 4,800 cubic yards of a special aggregate. And the installed unit cost for that concrete is about $1,300 per cubic yard. You still have to pour a single floor room for the LEO solution, but it's a much reduced amount of concrete. And so that delta is somewhere around, in our experience, some 3,300 cubic yards of concrete that we eliminated by not rotating the gantry. And at that price point in today's dollars, it would take me almost $4.3 million to pour that concrete. Then you have the normal infrastructure to support the 128-degree gantries. The power consumption, well, that's an operating cost, but the cost of the electrical infrastructure, cooling and all of that adds an infrastructure cost to you that we valued at $1.1 million. And then, if you can imagine building a 3-story gantry, a 3-story vault, the amount of time it takes to build that versus a 1-floor, basically linear accelerator size vault, can add a year and a half in our case, and we pride ourselves in building quickly, saves a year and a half in construction time. So that reduced schedule to design, not to mention your carrying costs if you're like us and you borrow money and you have interest payments on the construction debt. So that comes out to another 1.2. So our experience showed us if we'd have selected LEO for 1 vault, we would have eliminated about $10 million of capital cost. That's a lot of fractions to get reimbursed for, to pay for that additional cost. So having said that, it's been my experience that by making that simple leap of let's treat patients in a more humane way, treat them in the upright, let's rotate the patient around the beam and not the beam around the patient, that we can improve access to proton therapy by reducing the initial capital cost to institutions. And so that is our experience, and I appreciate you taking the time to listen to me today. Thank you.
Can you pull up my talk? All right, thank you. Well, good afternoon. My name's Chuck Enck. I've been the chair at Nebraska, the inaugural chair, since 1998. I'm going for 30 years. I fear that'll be a difficult record to beat at Nebraska. But I'm here representing our experience regarding proton therapy. And when I thought back and looked at that, I think we are actually more than 30 years in considering about proton therapy. We tend to be a little conservative in the Midwest. We don't move too fast. Pertinent to this discussion, I do not have any conflicts of interest to disclose, but just a quick review of the timeline. So in 1994, I didn't become chair of the inaugural chair until 1998. Dr. Chancellor Moore, who was a pediatric hematologist oncologist, said, we should do proton therapy in Omaha. And I knew he was passionate about that from the standpoint being a pediatric hematology oncologist, but then I did a reality check. I think at that point we had maybe 3 physicians, 3 physicists. Loma Linda had opened in 1990. It was a multi-gantry room, a much bigger access to patient population than Omaha at that time. Currently, we're about a 1.1 million metro area. A much larger service area. But that was also a time that image guidance was really starting to come on in the photon portion of radiation oncology, and I was really into that. We adopted a lot of the very first image-guided technology, and I was like, what does it matter if I have a Bragg Peak, if I have a Ninja sword, if I have a blindfold on? So I wasn't that big on proton therapy at that time. I had the privilege of seeing the Siteman Cancer Center in 2013 or 2012 when they were doing the first install of what today I guess we would call the Mevion S250i. I know it wasn't quite that version, but I saw it before the patient floor in the middle was installed, and the massiveness of that equipment. From a guy standpoint, it was really cool because it was massive, the counterweights and so on. And we considered some of the compact proton options in 2016, and that was with a different chancellor. But he thought, well, let's get it and then figure out how we're going to pay for this later. And they were going to do a third party, and I looked at the financials and was like, this is a really bad idea, and said, don't do this. We will not do well with this. And so my hopes were dashed once again. And then in 2021, 5 years later, we started that process again. Our performance said, we're probably going to need 2 rooms. We don't need to build them both at the same time. University of Kansas had done a project where they were going to build 1 room and have footings for the second, add that when they needed it. And I thought that made sense. Went back to administration. They said, well, of the multiple acres of campus land that we own, this is the one site you can have. And it's going to house neurosurgery, neurology clinic program, and you'll put your proton therapy there. And radiation oncology was supposed to be right there. Now, I won't identify any vendors by name and give them free advertising, but that institution is noted for doing something called the cheese Frenchie, which is a deep-fried grilled cheese. So when I was heard at the presidential about the metabolic dysfunction, I was like, yeah, that. But I was concerned when I looked at who our neighbors were, and you had 1, 2, 3 hotel facilities that were actually just built for the kind of the growing campus for medicine. And when I looked at that, I said the way we're going to build it was the first treatment room would be built on the opposite side of that street, more where the fast food restaurant was. And the second room would be built at a later time closer to the street that serviced the 3 hotels. And I said, we're going to lose the lawsuits that they will bring against us when we close their access to their 3 hotels down for more than a year for construction. I said, we have to do this at the same time, which means now it's a $100 million project, and being conservative in the Midwest, they said, yeah, okay, well, we're not going to do that. So my hopes were dashed once again, but I remember as we had been doing our exploration into proton therapy, I had the opportunity to hear Nick Schroeder give a presentation at one of the NAPT meetings about upright positioning for not only proton therapy, but photon therapy. And Nick, if you've never met him, is extremely passionate about what he talks about. Oh, he's back there. And And I knew there had been discussion with Mavion and doing an upright proton, really compact solution that would fit in a LINAC room. So I looked and I emailed him in April of 2023 and said, hey, I'd like to revisit this conversation. And we invited them out to the Cancer Center. And they gave a presentation with Lionel Boucher from Mavion. And they said, you know what, we think this would work. The Mavion fit would fit in our LINAC room, and it just so happened when we designed Buffett, I made darn sure we had an extra treatment room for whatever, capacity growth, new technology. I definitely wasn't thinking of proton therapy, or when it was time to start replacing equipment, we went in a round robin. So they gave the presentation in April. We did the feasibility. It looked like we could do it. I felt we really should have a patient positioning room built separate. We had space available for that, thanks to COVID and the dosimetrists all going remote after that. And we started fundraising in late 2023, and by the beginning of 2025, we had raised $24.5 million of a projected $36.1 million project cost. Thank you, Berkshire Hathaway. We have a lot of wealthy people in Nebraska in that area. We signed contracts on January 31st. On March 31st, we began construction. Obviously, we had already started the design process before that. And of course, as you had heard earlier from Steve, we had Leo Cancer Care receive their 510K clearance for Marie and Eve. And September 15th, Mavion received their 510K, which took a lot of weight off me. So this is Eve. So this is what we'll use for saving time, keeping patients out of the treatment room while we're designing their positioning device and or immobilization device. And then Marie with the built-in CT. So there's some extra exposure from CT, but it's still minimal compared to what we do with photons. And I mean, that's the ultimate in image guidance, to have diagnostic CT quality. We actually had a CT on rails, and compared to KV, it's still really good. So what are some of the advantages of upright proton therapy? Certainly, the really compact design allows proton therapy in a LINAC room. And by doing that, if you can build it on site, you don't have to build a separate facility like we were doing before. I don't need separate treatment rooms. I don't need a CT simulator room. I don't need exam rooms. All that infrastructure you avoid, and the need to duplicate all the staffing positions is also substantially less. So in terms of operational costs, you've cut that down significantly. But for certain patients, upright treatment is it's clear that that's probably a preferred treatment option. If you have somebody that's prone to aspiration or excess secretion, treating them upright is a much preferred option. And even in the studies that have looked at patient preference, previously treated radiation therapy patients who had treatment in the supine position versus upright, they prefer upright by and large. So as has already been alluded, there are significant ways to reduce expense costs for construction, but also time to execute. I think we're going to find, I'll predict, there's going to be a lot less wear and tear on critical pieces of equipment. And I think probably the operational uptime is going to be significantly improved with upright systems. That's a prediction that I'll make. And I think by cutting costs, it's going to allow more institutions to say, you know what, the finances are such that we think we can do this. And instead of this modality only being available to 2% of U.S. Radiation therapy patients, I think it'll broaden that significantly. So I think things that, if you're considering doing what we did with a retrofit, things that you need to consider is, are you going to continue to treat patients during treatment? Because that's going to influence some decisions you make. How are you going to get the accelerator into the room? We have 7 stories of building above us. I'm not going to be lowering it in with a crane. Do you have the additional space? We say it can fit in a room, well, in quotations, because you still have your additional support equipment that has to be positioned outside the treatment room, and you need to have room for that. Your clinic space, we just said we're not going to duplicate a facility, but I'm going to have the proton patients that we're seeing in consultation. We anticipate a halo effect with additional patients coming in for additional radiation, and we had to build in some extra exam room space by repurposing space in our clinic area to prepare for this. And then we won't have space to store all of the patient positioning devices in there. And so you have to think of options. And what we'll probably end up doing is having essentially a rack system for 5 or 6 patients at a time where we can wheel that in. We're done with that group, we wheel it out, we wheel in the rack for the next group. So those are things that we were thinking about in making up for the fact we didn't design this from the beginning. And then the other thing would be is a decision you need to make. Do you think you have enough time in your daily treatment that you can do both the positioning and CT acquisition, or should you have a separate room for positioning? And we built a separate room, and we thought further ahead and said at some point they're going to have a CT simulation option available for this equipment. We built in all the infrastructure for doing CT planning, including a control room. So that's actually in the middle of our treatment day, and believe it or not, all 3 of our photon rooms in our principal building had patients in them at that time. That was one of the radiation therapists who I said photographs are always better when you have a figure in it. But that is what is essentially the interference from the construction project. So everything is being done outside of the main clinic space, and the same thing in our simulation HDR brachytherapy suite that's adjacent to the treatment hallway. And this is how we're going to bring all of our equipment in through that doorway. I think they'll be taking the doorway out. And the rigging company says, well, to get the Mevion cyclotron in, they will be tipping it in at an angle to bring that in. Okay, now we have it inside the hallway. Now what do we do? And they said, we're going to cut a hole in the wall. Now, I took that picture with one of my iPhones, and I said, do you have any idea how much rebar is in that wall? And I pictured Shawshank Redemption and Andy Dufresne with this little rock hammer, thinking how many thousand years it was going to take to get through that. And I think it was somebody from H&H Construction who came with that first site visit. And they go, oh, it's standard rebar concrete, no problem. And I'm like, okay. So, well, there was the hole in the wall. It took them about 8 days to do that. There was no jackhammers, there was no dynamite. We didn't bring the 7 floors above us down on top of us. I don't want to waste time to tell you how they did it, but it's actually quite ingenious. So if somebody wants to hear about a rope saw, I'll be happy to tell you. But that was a picture from last Monday, and they're pouring the final finished floor of concrete this week on the room. They will close that opening up, obviously, and add steel. They're not filling it with concrete because they don't want settlement in a gap. So they'll use more of a block, shielded block construction, put steel over it. Unfortunately, we're probably short several inches of concrete above us for shielding. No problem, they're going to attach 6 inches of steel plate to the ceiling with no side support. I said, will you guys be the first one in when you're done with that to test that? I think they talked about this product called Alien Tape that should do the job. All right, so our timeline, we started construction truly on March 31st, and we plan to actually go clinical in March of 2027, and I think that's a very realistic timeline. One of the nice things coming to ASTRO is I sense that there's a little concern about the accelerator being delivery on March 14th, and maybe it'll be 3 weeks behind. But I will tell you, Maria's already in Omaha, waiting to be installed. So that is going to be my new license plate. Currently, my license plate says Beam for NU. We won't talk about the Michigan game last week. And that's the Buffett Cancer Center. Thank you.
Those were two absolutely fantastic talks. Engineering genius, I have to say. Do I have my presentation up? Okay. So let me start with my conflicts of interest disclosure. The most relevant one here is I'm on the scientific advisory board of Mevion. But as I sit through and look at people here, I don't think that's the most relevant one. I think the most relevant one is I've known and worked with Rock since 1987. I think that's an absolute conflict of interest. But anyway, what I'm going to do today is to give you a little history of the radiotherapy chair. That just sounds so gloom and doom, the chair, you know. So I'll try and make it a little fun. We'll talk about the NIH chair because that in some ways is one of the things that started a lot of this. We'll talk about radiation therapy facilities in the United States. I want you to get a sense, especially in the photon world, where the chair could have a place, and I think getting a context of radiotherapy facilities helps. And then we'll talk about chairs in proton centers, but more importantly, I want to give you a couple of examples of where the chair can be value add from the perspective of not just being a physical enrichment to facilities, but providing biological advantages. So with that, let's go first with the legacy published history. I'm sure this history is only partial because there must be many examples that are unpublished. So one of the first examples describing the chair goes as far back as 1956 in the British Journal of Radiology, where Morrison and colleagues described a chair for the LINAC that was put at the MRC, the Medical Research Council, with an 8 MeV beam. A few years later, there's another example of a chair also described in the British Journal of Radiology. And then a chair is developed for the Betatron in the early 1970s. And subsequently, in the same year, a specific chair for head and neck radiotherapy was delivered with a 45-degree tilt, so you could tilt the patient. And this too was published in the British Journal of Radiology. So as you can see, all of these first chairs somehow make it in the British Journal of Radiology. I think the British have a fixation with the chair. I do want to point out that there used to be a commercially available chair, the Variant chair, which used to be offered as an accessory that one could buy. And actually, during my residency, I remember actually treating one patient on the chair, and then we promptly got rid of the chair from the department, and then next time I got a patient with a superior vena cava syndrome who could not lay down flat, I said, where's the chair? So, oh, we got rid of it. I said, gosh, darn it, I could have used it, you know. And I remember that we all go through our training with a once in a while anecdotal case where we think we could use the chair. But of course, that has now changed to not being anecdotal, but to being more widespread. So let's look at the 1991 NIH chair. Eli Gladstein was the force behind this chair, and they, in fact, thought about such cases. Patients with large anaplastic thyroid carcinomas who couldn't breathe because the tumor was wrapping around the windpipe, big superior vena cava masses, patients could not lie down flat, mediastinal syndrome in kids, bleeding head and neck cancer patients who would choke if they went backwards. So for all of these very complex esoteric indications, they decided to develop this isocentric chair. And it's actually a pretty fancy chair, and I thought this was just going to be esoteric. But if you look at the senior author, it's Eli Gladstein. What did Eli do? He treated lymphoma. He loved treating lymphoma. And so as you can see over there, it's a mantle field. That's a mantle field with a Hodgkin's lymphoma patient being treated by Eli in a chair. You know, who would have thought? You know, so that's a pretty elegant use of the chair. And this is as far back as 1991. Now, the reason I give you these examples is because we've heard two excellent examples of the placement of a chair in proton centers. And although proton is growing faster than photons in the United States, at a rate of 15% per year in terms of the number of fractions delivered, compared to half that number, 8.6% for photons, in reality, only 2% of all fractions that are delivered in the United States are delivered with protons. So although the rate of acceleration of the number of fractions delivered is higher for protons, the market size for photons is much, much, much larger, at least a 2-log difference in terms of what could be done. And so, in fact, if the chair could have a place on the left, that place would be much, much, much larger than the place on the right. So let's put that in context. If we think about radiotherapy in the United States today, there are 0 PNCT facilities in the United States today. The University of Wisconsin just announced a memorandum of understanding for potentially the first one. There are 46 proton centers with 116 rooms. And obviously, this is a dramatic escalation from just about 6 or 7 years ago when we had less than 12 centers. But there are 4,000 LINACs in 2,500 facilities. So think of this scale in terms of the differential. And if you globalize this, the scale becomes even larger. So with that, let's just talk about the proton chair very briefly. This is the very first proton chair that nobody actually talked about. Any Star Wars fans in the audience? You know, so this was a mind bender. It was a mind evaporator, but this was the very first proton chair ever described. Of course, you had to be in the Star Wars era to actually get this. But this is the real proton chair, right? So Northwestern was one of the first to put in a proton chair because they wanted to use their nozzle, and they did quite a bit of extensive work on this, treated a number of patients, and there's extensive publications on what they did with this work. And that's where the Leo proton chair now comes in. It's revolutionizing what we can do in terms of positioning patients. It's much more elegant. It's got effectively a diagnostic CT on top of it, acts as your simulator, acts as your machine for adaptive radiotherapy, potentially even daily adaptive radiotherapy that could be done while the patient's still in the machine. This kind of a chair can revolutionize miniaturization of proton therapy for systems like PCure, Mevion, and others to come in the future. As we heard, it lowers the capital cost by eliminating the gantry, and clearly this can make protons much more accessible. It democratizes access to proton therapy. So let me now give you some value examples using biology as a driver, potentially in the future. So this is a kid with craniopharyngioma, central tumor, ideal patient for proton therapy, treated with a 3-beam arrangement using an SFO technique with 3 couch kicks, robustly optimized. CTV is identified very clearly in the target here. There's a 3.5% range and plus minus 3 millimeter setup, robustness optimization. Beautiful, elegant plan, staying away from the temporal lobe, staying away from the hippocampi. Couldn't get better. 6 months later, if you look at this patient's scan on top, all of these enhancing changes throughout the brain. This is with proton therapy. This was a fantastic plan. The total dose is 54 gray at 1.8 gray per fraction. What went wrong? There are all these radiation-induced contrast enhancement changes. We call them RICE. And this is a dramatic example of RICE. Now I'm showing you an extreme example. We've done a thorough analysis. This happens about 15% of the time. Not this extreme, but it happens about 15% of the time. And of course, you have to wait, because when you first see this, you have no idea what the heck you're looking at. You freak out. You wonder, is this leptomeningeal carcinomatosis? Is this spread of disease? It's actually an inflammatory change that goes away. And 12 months later, this has all gone away. This was all thanks to this 3-beam arrangement. It was this 3-beam arrangement that gave us this gift. So why are we seeing this? What's going on? We never see this with photon radiation at 54 gray. We'd never see this at 54 gray. And the reason we think this is happening is we think that the physical dose and the bioeffective dose of proton and of proton radiation is simply a 1.1 multiplier. So you take the spread out Bragg peak, you put a curve 10% above that Bragg peak, and that's your proton dose. But it's not, because in reality, distal to the Bragg peak, just distal to the Bragg peak, the biological dose climbs dramatically. And this is not a 1.1 multiplier. This could be a 1.2, 1.3, 1.4 multiplier. So this could be a significantly higher dose just past the Bragg peak. And we really don't know exactly where this locates. That's just one of the variables. We've now done a very thorough analysis of a large data set, and there are multiple other variables that contribute to this, but it's all because of the beam characteristics of the proton beam, all because of the fact that we deliver the beam from 2 or 3 or 4 fixed fields in a few directions. The beauty and advantage of the chair is that we can now actually rotate the patient. So we took the same patient with a 3-beam arrangement and asked the question, what would happen if this patient was planned with proton arc therapy, which is made possible and feasible by the chair because the patient can be rotated around and multiple different angles can be used to deliver this. And so you can see the IMPT plan on the left and the dynamic arc plan on the right. And at first glance, you would surmise that there is a greater low-dose bath from the dynamic arc plan than there is with the IMPT plan. Maybe the chair is a bad idea. Maybe rotating the patient is a bad idea. You get a greater low-dose bath. But when you actually correct this for LET dose, you actually find that all of that spread out Bragg peak, which is the problem, dramatically diminishes this because there's no single beam that is delivering a high enough dose that you run into an LET-related problem, and you can potentially eliminate this radiation-induced contrast enhancing changes. I think with the installation of the FIT systems that we're seeing, this could be one of the first questions that could be answered, whether this makes a biological difference and outcomes can be changed in patients. So the chair may not just be about positioning, the chair may not just be about positioning a patient, but it may be about changing biology. Let me give you another example of potentially changing biology. This is a patient with a 4th recurrent glioblastoma, so you can see that massive contrast enhancing change in the temporal lobe with a significant amount of flare abnormality. She was in her late 30s, was referred to us for re-radiation because she had previously had radiation twice and 2 surgical resections. We looked at this and we said, there's no way we can do this safely. The optic nerve is there, the optic chiasm is there, the pituitary gland is there, the brainstem is there. This can't be re-radiated. That's an impossibility. Your answer is hospice. Sent the patient into hospice care. A couple of months later, she got clinically worse, insisted on pulling herself out of hospice, came back for another MRI, and as you would expect, it's dramatically worse. So this is the 5th progression. Everything is worse. Half the brain is involved with the tumor. We took this patient. We didn't know what to do, so we took a technique that we had worked on in the world of photon therapy, which is pulse-reduced dose rate radiotherapy. Did a lot of extensive investigation to see if we could do this with proton therapy. We then developed a specific technique for pulse-reduced dose rate proton therapy. She became the first patient ever in the world to be treated with that on a compassionate use basis because we had just patented the technique and we had developed a clinical trial which had not yet been initiated for her. And we treated her. And we gave her 45 gray to the whole volume, all of the flare, all of the enhancement. As you can see, the whole thing is treated. And at first follow-up, 2 months later, all of it is gone. A 5th recurrent glioblastoma treated with 45 gray, and you can get a complete response. It's unheard of. Of course, we are drastically concerned about all of the high LET issues around the edge, past the Bragg peak. And think about where that falls, right near the brainstem there. So we could easily knock off a number of cranial nerves. Right along the optic nerve, we could easily blind her. So yes, this is a technique for doing something elegant biologically with patients, but imagine if you could deliver this with a chair. Imagine if you could spread this dose with the chair so that all of this is not the high LET edge of the dose. You could clear that out and potentially get extra biological benefit. So we currently have an ongoing trial called the popcorn trial where we're testing this. We don't have a chair. We're testing this technique of pulse-reduced dose rate radiotherapy. So I think Marie, that you've probably all seen, has significant value, not just in the world of proton therapy, using case examples that I've shown you, but I think more importantly, in the world of photon therapy. It will democratize radiotherapy access globally, not just proton therapy access. Because just as you can get rid of the gantry in proton therapy, you can get rid of the gantry in photon therapy. And if you've looked at the United Nations report on the need for linear accelerators globally, I think it's an excess of 4,000 or 5,000 linear accelerators that are needed to reach even medium country level access to radiotherapy. There are no finances or economics that provide for that, but democratizing access can be possible with just a single beam and a chair positioning. So in summary, chair-based concepts are not new. They date back to the 1950s. They were really designed to solve unique, boutique, specialized problems in the clinic. There are several legacy examples that we have. And in a number of patients, these legacy examples were designed specifically because they were superior. They were better than the conventional approach of laying a patient down flat. But I think looking forward into the future, we can foresee a number of examples where this could become routine because, in fact, it is a better way to treat patients. Some patients simply cannot be treated prone or even supine, and those would be ideal for the chair. Proton gantries, as we have heard, are a major cost factor in the world of delivering proton therapy. Just 15 years ago, we had 5 proton centers in the US. Today, we have 46. But imagine if you took the globe as your prerogative. If you looked at the globe, you're never going to get to even 1% of all fractions in the world delivered with proton therapy unless costs are dramatically lowered. And the chair is one way of doing that. Chair-based proton therapy can easily permit things like arc therapy, proton arc therapy, which can overcome these high RBE challenges that we see in many situations. Longer treatment times, such as PRDR, which is what I showed you in that case with the recurrent glioblastoma, can much more easily be delivered with a chair. That treatment takes 45 minutes to deliver. Imagine a patient with a 5th recurrent glioblastoma lying prone or lying supine with a mask in place. It's going to be very complicated, but a chair would be a much easier way to do that. And obviously newer technologies, such as carbon therapy, boron neutron capture therapy, et cetera, this would be a very good use case for this. And of course, finally, I think with the advent of GRACE, I can say gracefully that low-cost LINACs with chairs would improve global radiotherapy access. And I think therein probably lies the greatest value case and value proposition for the chair. Thank you.